Yes, I am very much interested, and I have a deep uh, interest in endoscopic procedures. And today I would love to have the chance to have a talk about the complications that could happen in endoscopic procedures and discuss a little bit on the prevention strategies for those. So, why do complications matter in endoscopic spine surgery? We all understand the concept, the advantages of endoscopic procedures. We're trying to be as least invasive as possible when we are trying to treat a target lesion. In the past, we did a larger destruction to get to a focused small area. But now, thanks to the new techniques, thanks to endoscopic procedures, through a very small corridor with minimal adjacent injury, we can treat a lot more wider area inside there. But we need to understand that minimally invasive does not necessarily mean it's risk-free. There are always a different risk. So we need to admit and we need to understand that there is a steep learning curve, which means that the early adopters, the learners, will face the highest risk in the beginning. Another thing we need to understand is that there are unique complication profiles compared to open procedures because the surgical procedure itself is completely different from what we used to do. Another reason that complication matters is because our outcomes, our problems that we have right now, will be directly affecting the credibility of the technique itself. So how are they different compared to open surgical procedures? In our open surgical surgeries, the problems are usually visible, they're manageable. They happen in real time and you directly see them. But in endoscopic spine procedures, they typically are silent until they become not silent. Bleeding, a dural injury, a missed fragment, incomplete procedure. These kind of problems are usually hidden until we find it delayed. So this means that endoscopic spine surgery related complications are fundamentally different from open procedures. Because of its limited workspace, its limited instruments, its unique water dynamics, or its steep learning curve, they are totally new failure modes. And they typically get delayed recognition. And not only to mention endoscopic procedures, but all kind of procedures, recognizing risk before it actually happens is much more a valuable surgical skill. So I want to emphasize that understanding the complications themselves is not a reason to avoid endoscopic spine surgery, but it's more of a reason to understand it deeply. So what can happen? If we look back into the history when we have new techniques, they when they go wrong, they typically end up at disasters. So just like any other surgical procedure, any kind of complications can happen in endoscopic spine surgery. Not to mention incomplete surgery or recurrences, but more even including more severe complications like neurovascular injuries or dural injuries, anything can happen. So let's have a look into a step by step and have a more detailed look into the complications. Every image you will see in these slides are every single slide are my cases. So I've been through all of these complications. So incomplete surgery is a very common complication. I don't know if we can call it a complication, but it happens a lot. And if we look into the literature, it is reported that up to 2 to 3% of cases are incomplete uh, surgeries. So to avoid an incomplete surgery, it is important to have a very extensive preoperative planning. And it is also important to have an optimal approach with precise surgical targeting. So landing on the right spot means that you have a better chance of avoiding incomplete surgery. Additionally, there are some certain clues for decompression, which gives you a pretty good estimate that you have a sufficient decompression intraoperatively. So one of the things is having a look into the pre-op images and measuring the size of the disc, but this is not always useful. Intraoperatively, you can see and observe the free mobilization of the nerve root, careful examination on the shoulder and the axilla as well. And spontaneous pulsation of the dura is also a good clue that you have decompressed the nerve root. A vascular refilling of a pale nerve root is also a good sign, and restoration of normal anatomy, which was distorted due to the disc or the compression. When you see them restoring back to normal anatomy, that's a very good sign of good decompression. To mention about transforaminal surgeries, another good way to avoid incomplete surgery is to have a better view from the beginning. If you start from the trans-SAP area, if you start from taking out part of the SAP and land inside there, it gives you a much better view of the dural structures, which means you have a better chance of taking out all the needed amount of decompression. Let's talk about recurrence. In previous reports, it typically reports around 1% of early recurrence after surgery, but by our experience, we know that recurrence can happen a lot more than this reported numbers. I think you might have been through these questions from the patients. Does it recur more than open surgery? If you look into the literature, the answer is no, the numbers are not different, but the timing of recurrence is a little bit different. Typically, in early phase, it seems to be like endoscopic procedures have a little bit higher incidence of recurrence. But if it goes to midterm or long-term follow-up, endoscopic procedures have a lower recurrence rate compared to open procedures. So in overall number, the recurrence rate are similar, but the timing of recurrence are a bit different. We need to understand how this works. There are some certain ways to prevent the recurrence and lower the recurrence rate. One of the easiest way would be doing a little bit more aggressive discectomy. But we need to understand that doing a more aggressive discectomy would lower the risk of recurrence, but at the same time, in terms of back pain or functional back pain, functional outcome of the procedure, then limited discectomies are better than aggressive discectomies. So this should be more of a case-by-case, patient-by-patient decision based on the surgeon's experience. If you do a transforaminal procedure, exiting root injury is one of the most unique complications that can happen in an endoscopic procedure. It is well documented and is well reported that in certain cases after transforaminal procedure, you can have a exiting root injury. The reason that we meet these problems is that the exiting root is just adjacent to the facet joint and is just coming out from the foramen where it is actually we are targeting to get through. We have this nice report coming from one of the Korean colleagues that if you have a good look into the pre-operative images and see the proximity of the nerve root to your corridor, you have a better understanding of the risk of exiting root injuries. So once again, if you come from a more shallow corridor and take a little bit out of the ventral part of the SAP, there's a lower chance of exiting root injuries. You can see this on the pre-op images. If you see a sagittal image showing the nerve root just adjacent to the disc level, there's a little bit higher risk of exiting root injury during the procedure. But if you see the exiting nerve root a little bit away from the disc level, that might be a better chance of safer procedure. One of the easiest way and safest way to decrease the risk of exiting root injury is using a trans-SAP approach for transforaminal procedures. If you look into the Campbell's triangle, the SAP, ventral part of the SAP is the spot which is most far away from the nerve root, which means this is the safest point. So if you do a trans-SAP and ream or drill out a little bit of the ventral part of the SAP, there's a much larger chance that you are getting away from the nerve root and it's a much safer procedure and lowers the exiting route injury risk. Before I did trans-SAP procedures, I think I had 3 to 4 exiting route injuries out of 100 cases. After I started trans-SAP, I had only one single exiting route injury in more than 300 cases. So this gives you a pretty good clue that this is much safer to do it this way. Let's have a look into another complication, epidural bleeding. If you look into the images here, we all understand what would happen if you see these post-op images. So if we look into the incidence itself is very low. And out of more than 10,000 cases, the incidence of PLD-related post-op hematoma was 0.1%. However, this is clinically relevant post-op hematoma. If we look into the literature, it reports that asymptomatic radiologic epidural hematomas occur in 30 to 80% of the procedures, and 5 to 10% of the procedures are symptomatic. Not all of them require surgery, but at least 1 or 2% of them end up requiring a surgery and a surgical evacuation of epidural hematomas. Sometimes not only epidural hematomas, but also retroperitoneal hematomas could happen. And these could be life-threatening complications. Very rarely, but they can happen. So when we look into the procedure itself, what we expect is a nice, clear vision of the surgical field, but reality is not like that. We easily end up in this red, bloody vision. So how can we avoid bleeding and how can we prevent bleeding? I think the most important thing is understanding the vascular anatomy. If we look into the anatomy, it is very well recognized and very well documented that the area just at the ventral part of the SAP is the area with lesser bleeding and a lesser vascular structures. If we look into them a little bit more with more detail, once again, it's really important to understand the vascular anatomy. If we understand the vascular anatomy, we know how to avoid injury because we know where the vessels are coming from. And even if we do have an injury and we do have a bleeding, we know where they are coming from. So it's easier to control the bleeding. If we look into the arterial supply of the spine, the segmental lumbar arteries directly come out from the aorta and they run distally, giving branches, one to the foramen, inside the foramen, and the others surrounding the facet joint. So this area, the distal end ends up in the foraminal area. So if you reach the foramen, there's a chance that you will meet a arterial bleeding. And once again, these distal branches surround the facet joint. So once again, at the lateral part of the facet and the inferolateral part of the facet, there's another arterial supply. So you can easily meet these arterial bleedings here. The final distal branch ends at the upper surface of the lamina. So when you do an interlaminar procedure, just above the lamina is the point you would expect another arterial bleeding. Under the lamina, intracanal is also having a very unique vascular anatomy. And if you look into these anatomy, there is a very complex anastomosis of these venous plexuses. Especially when you drill through the lamina, the upper end of the caudal lamina, and reach the lateral recess area, there's a specific venous structure here. So this is where you might expect a venous bleeding as soon as you remove the ligamentum flavum and reach the lateral recess area. So once again, if we do understand these intracanal epidural vascular structures and know the anatomy, once again, you can know how to avoid them, and it becomes a expected bleeding, not a unexpected bleeding, which means it's easier to control. Now let's have a look into the detailed techniques to do hemostasis. Typically, irrigation itself is a really good friend of ours. If you mix a epinephrine, itself has in the saline itself has a vasoconstrictive effect, and it helps you control the bleeding, especially the minor bleedings. And constant irrigation with a certain amount of water pressure itself also gives a gentle pressure in the epidural space, which is a good way to control these minor bleedings. Even if you do have an excessive bleeding and a larger bleeding, it can be easily managed by transiently closing your outflow, which increases the epidural pressure and it will gently stop the bleeding. If you don't have a view, if you have these all red turning vision, you can intermittently flush your syringe and it gives you an idea where the bleedings are coming from. The only thing you need to be careful at this point is being careful of increased epidural pressure. But in general, a very short term of flushing would not affect the patient. Other than those major bleedings, you can just simply ignore minor bleedings if they do not affect your procedure. They might just flow away with the saline irrigation. Another tool is radiofrequency, of course. These are extremely effective in controlling small vessel bleedings or soft tissue bleedings. And when they're used well, they can even control bone bleedings as well. One point that is important is that you need to be very intermittent, precise, but at the same time, it needs to be a very short time, brief, intermittent shooting. Otherwise, it could end up in adjacent neural injury due to the thermal effect. So it is well known that if the temperature exceeds 60 degrees, it gives you an irreversible protein denaturation injury, which means that it may end up in a permanent neural injury. Once again, it is very important to have an intermittent shooting of the RF during surgery. Many surgeons, especially in their early career of endoscopic surgery, many would have difficulty in controlling bone bleedings. However, we can understand that most of these bone bleedings don't come from the cortical bones. They mostly come from trabecular bone. And if you have a wide surface RF, it really helps you do coagulation on the bone. If not, you can also always use a diamond burr, which generates much higher heat energy, and it also helps controlling the trabecular bone bleeding. Alternatively, you can use the kerosene ronger. If you bite it and just not cut it and take it out, but gently compress it with the bite, it also helps you control the bleeding a little bit. Another technique is using the surgical patties just like the way you use them for open procedures. You can cover the bleeding, you can block the bleeding, push it inside where the bleeding is coming for a while, and it just blocks the bleeding coming out, which gives you a better view, better understanding of where the bleeding is coming from. And at the same time, it gently compresses the bleeding and can be hemostasis right there. You can just gently compress it and just leave it there for a while and come back afterwards. And it is effective for most of the low pressure epidural bleedings. Even if you don't have a patty or if you don't put a patty, sometimes just leaving the bleeding for a while could also generate a certain amount of pressure. And sometimes they just stop themselves. So just leave it for a second and come back in a while, and they could be easily controlled in many cases. When you want to use bone wax, you can just simply apply a little bit of bone wax on the tip of the patty, cotton patty, or otherwise on the side of the dissector, and just apply them just like you do in open procedures. Thanks to the industry, we have various hemostatic agents, active hemostatic agents, including Flow-Sil, and using these products remarkably lowers the risk of epidural hematoma. And this report, we can see that it's not clinically relevant hematomas, but if we look into radiologic epidural hematomas, there was a significant decrease of hematoma after the surgery if we apply preventive flow seal for the procedures. That is what I do in every single cases. After the procedure is done, even if I do not see a certain bleeding, I always apply a flow seal because in many cases the bleedings are invisible just because of the water pressure. And when the water is gone, they can bleed again. So I typically do a preventive flow seal apply after the procedure. So hemostasis is not just a simple technique, it's more of a constant combination of OR setup or, or available techniques or even the products. So by the combination of these, we could easily and effectively control the bleeding. And at the end point, you can double check by turning off the irrigation and see if there's any further bleeding coming from the surgical site. Typically for uniportal procedures, I do not put a hemovac in most cases. Now let's move on to dural injuries. Iatrogenic dural injuries can happen at any point after a endoscopic procedure. Just like I mentioned earlier in the talk, the problem of endoscopic procedure is that you can easily miss these dural injuries because you are basically working inside the water. When you are doing an open procedure, you will see the CSF just gushing out and you immediately recognize the dural injury. But in endoscopic procedures, because you are already working inside water medium, you can miss that fact that you have made an injury. So incidental dural tear can happen at any time. So it is extremely important to understand you only grab, bite, cut, pull, retract, or whatever, only after you believe you did a precise, complete dissection between the dural structures and the adjacent anatomical structures. It's not only in transfemoral procedures, but also in interlaminar procedures. It is important to make this precise dissection prior to any manipulation on the dura. If we look into the anatomy once again, the most vulnerable point, the most frequent point of dural tear is the midline of the dura. If you look into the images right here, you might see these midline dural folds on the dura. If you look at the anatomy, these are the area where there is a certain ligament holding the dura to the ligamentum flavum. So if we just do a procedure underwater, the water pressure could gently push the dura down, but the point here at the midline is still attached to the ligamentum flavum through this ligament. So this raised point, the dural fold, is where you can easily make a dural injury. So the tip is you need to always keep the ligamentum flavum as far as possible during laminectomy procedures because the ligamentum flavum will play and serve as a protective measure for dural injury. And repeat dissection and detach the dura from the ligamentum flavum precisely, and only after they're completely dissected and detached, you can safely take out the ligamentum flavum from the dura. Even after these thorough maneuvers, we can still have dural injuries, and there are many different ways to repair the dural injury. You can directly repair it. You can put some sealants on it, just like Tacosil or Duragen. What I typically do is when I do a procedure and I suspect dural injury, if it is a local anesthesia case, I would just stop the irrigation and ask the patient to cough. If it's a general anesthesia, I would turn off the irrigation, ask an anesthesiologist to do a Valsalva maneuver and see if the CSF is coming out. If you have a dural tear but don't see the CSF, it means that the arachnoid membrane might be intact. In these cases, a simple patch or a Duragen are typically sufficient enough for dural sealing. However, if you do see a certain amount of CSF coming out, if you see the nerve roots coming out, herniating from the dura, then it's a very good clue that you need to repair it tightly. And if you do not have the abilities to do the sutures intraoperatively, then open conversion is the golden standard yet. Let's move on to infection. Just like I mentioned earlier, the infection rate is lower, but it doesn't mean the infection rate is zero. It is reported that open procedures have a approximately 3% risk of surgical site infection, and the infection rate in endoscopic spine surgery is reported to be extremely low, far lower than 1%. However, once again, this means that it is much lower than open procedures, but it is not 0%. If we look into our instruments, they are extremely long tools with long lines, and this means there's a little bit higher risk of contamination when you're handling and handing over the instruments with your scrub nurse or your colleagues. So we always need to understand there's still a risk and be careful of these long instruments. Another point is that this is not a reported data, but one of my colleagues have experienced a consecutive case of infection, and the inner cannula were not cleaned well enough. So once again, we need to understand that the risk may be lower, but it has its own risks of infections, and we need to handle these. Wrong level surgery can occur at any time, especially for minimally invasive procedures. We need to double check, triple check the levels before the procedure. The last but not the least, we have water-related complications. So this is one of the unique water dynamic problems. If you have a higher water pressure related problem, it typically increases the intracranial pressure, and we can end up meeting these central nervous system related problems after a surgical procedure. If we look back into the existing literature, we have pretty good evidence that the adequate water pressure is between 30 to 60 millimeters mercuries. And if you don't have a well-controlled pump, this is equivalent to the height of the patient, about 50 to 80 centimeters from the patient's back. So it is important not to exceed this threshold. And if we once again, look back into the existing literature, it is reported that the pump pressure, epidural pressure of 60 millimeters mercury at the lumbar spine is equivalent to that of 37 millimeters mercury in the cervical spine. And these are related to significantly higher risk of increased intracranial pressure related problems. So it's important to remain below this pressure throughout the procedure. To summarize, the utilization of endoscopic spine surgery is increasing. We are using it more and more, and we have a lot more larger spectrum of diseases that we can treat with the endoscopic procedure. However, as the use of it increases, the complications inevitably increases, and these could end up in major clinical problems. And we need to understand the complications, keep them in mind, and be cautious of them and know how to manage them. But at the same time, I want to emphasize that we should not let them draw you back from trying and achieving endoscopic procedures. Thank you very much.
Yeah. Did you stop your screen sharing? Okay, Ella.
Sorry.
Ella, your connection is not good, I think.
Yes. Sorry about that. I tried to handle it.
Okay.
When I start to share my video, the Zoom is going very, very slow.
Okay,
Is it
I
possible
can
that,
I can handle this.
okay,
So first of all, there is two questions of mine. I can read it. Can epinephrine be used if there is a dural tear? This is one
Yes,
question.
yes, thank you. Thank you for this question. Actually, I recently have had this question at another conference.
Yeah.
What I do is, if I do not have a certain bleeding, then I would turn it off and just do irrigation without epinephrine. Typically, I have two bags prepared, one with epinephrine, another one without epinephrine. And when I have a dural tear, I would just turn off the epinephrine and just stick with no epinephrine irrigation. It's just because we don't know the safety of epinephrine in intradural exposure. But what I understand and what I have heard from many of my colleagues is that none of them have actually experienced any significant problems of intradural exposure of epinephrine with this, especially with this very low dose. However, personally, in my practice, I still turn it off unless you have a major bleeding.
What is the concentration of the epinephrine in the your SF saline?
I typically put a 1 milligram, one ampoule in a 3-liter saline bag.
And do you use the saline with epinephrine continuously without major bleeding?
In most cases, in my early practice, I used them routinely, but now I just use no epinephrine routinely and only switch it to epinephrine saline only when I have uncontrollable bleedings.
Yeah, but we can use continuously.
Yes,
There is no.
yes. In my early cases, I always used continuous epinephrine
So
mixed.
we can put one ampoule 1 milligram in a 3-liter bag, and then
Yes, that is what I do. Yes.
okay, thank you. You talk about the burst RF application. How long exactly the burst long? 1 second or more? And
Uh, yes, this is a very good. I typically keep it less than 2 seconds per burst. There's a report from one of our colleagues, our Korean colleagues, that with a small bipolar RF, even after 2 or 3 minutes, 2 or 3 seconds, the water temperature doesn't exceed 68 degrees, but still it is safer to have this burst as short as possible. And in these arthroscopic RF devices, they could easily increase the water temperature up to 50 or 60 degrees. So it is important to have a much even shorter burst of the RF when we're doing an arthroscopic RF.
and what is the power level? Do you use the highest level or
No, I always use the lowest possible.
lowest? Okay.
Yes.
Even if it is a burst, you use
Yes, I
low.
still want to make it as safe as possible. Yes.
Okay. And do you use it with coagulation mode or ablation mode in this burst?
Once I reach the epidural space, I never use the coagulation mode, but at the muscle or the lamina level, I use both.
Use both in inside of the spinal canal. You use
No. Outside of the spinal canal, before laminotomy and before flavectomy, I use both. But once I reach the epidural space and when the nerve structures are exposed, I only use coagulation mode.
coagulation. Okay, thank you.
Yeah.
And there are two questions from Ramazan. Actually, this is not directly related on the subject of the conference, but I will read anyway. What are your views on performing endoscopic surgery without stabilization in patients with minimal degenerative spondylolisthesis?
Yes, I think this is a very relevant question. I think it's very much dependent on the preoperative amount of instability. If the instability is minimal, just like you mentioned in the question, and it's a minimal degenerative type spondylolisthesis, I believe interlaminar decompression alone is a good option for these patients, especially as endoscopic procedures typically preserve many muscles even after the procedure. I think they're generally safe. But for high-grade spondylolisthesis, instability for isthmic type spondylolisthesis, that would be a different question. But to be limited to minimal degenerative type of them, I think decompression alone is a good option.
Thank you. And there is one more interesting question from Ramazan. If there is a intracranial pathology at the same time, and the patient needs the spinal surgery, do you prefer endoscopic surgery or microsurgery?
To be honest, I
Or
do. Yes,
history of intracranial surgery. Do you
yes.
think?
To be honest, I still do endoscopic procedures on these patients. I do not have many of these cases, but as working at a tertiary hospital, occasionally our brain surgeons would send patients with spinal pathologies, and I still do endoscopic procedures on them, unless they have a very significant intracranial pressure problem. To my knowledge, if we stick to the pressures that I mentioned earlier, lower 60 millimeter mercuries in the lumbar spine and under 40 millimeter mercuries in the cervical spine, if we do not exceed this threshold, I don't think it increases the risk of intracranial pressure.
Okay, thank you so much. And I think I have finished all the questions, but there are some colleagues. We also met in Mexico. We were together. Musa Ibrahim is here. Maybe he wants to say something about the subject. Doctor,
Hello.
hello.
Yeah, thank you for the.
Oh, you turn off your microphone again. Okay. You can turn on your microphone.
Do you hear me?
Yes, yes.
Yes. Thank you for the good presentation. Really lovely.
Thank you.
Yeah, thank you. That's all I can say.
Okay. Thank you. Also, Sadirip was here, but I think he left. If someone have a question or comment, we can give floor. Okay. So no one ask any other question. So thank you, Dr. Kwon, and hope to see you.
Thank you very much, Professor.
Okay. Also from İzmir says, great presentation. I appreciate it. Thank you. Okay. I hope to see you again in
Thank you very much. I hope to see you
Turkey
again
or
as
in
well.
Korea when I come. I will come in November. Yeah.
Oh,
Maybe
yes. For the spinoscopy meeting, yes.
I will be
Yes, I
there.
would love to keep in touch, and thank you again for inviting me to this
Thank you.
conference.
All right.
Thank you.
Also, I want to thank everyone who joined us today, this evening. Bye bye.